Mayor, you published a report on, in a way, non-responders to CLI therapy some time ago, because it seems that there are a fair number, growing number of patients who don't respond to therapy, and maybe you can speak to that and the incidence and some of the challenges associated with that.
Yeah, let me talk about this a little bit. In terms of the report, the whole purpose was to try and estimate how many people in the CLI category were the non-responders. And we define non-response as people who were revascularized successfully, but their wounds didn't heal, or they took really long to heal, and then they ended up undergoing amputations, generally speaking, major amputations. And in order to make those kind of estimates, we needed to identify the risk factors. So we went through list all kinds of risk factors and basically boiled it down to 5 major themes, or 5 major, what I call super factors. And the two super factors that stood out were microvascular disease, that is retinopathy, neuropathy, and nephropathy, and foot disease. And foot disease, also known as desert foot, renal foot, non-patent pedal arch, SAD, small artery disease, et cetera, et cetera. And then through these 2 super factors, a very common theme was diabetes and chronic kidney disease. So what we ended up finding was that approximately between a quarter and over 30% of CLI patients would fall into this category based on these risk factors. And it was interesting when we did the numbers, they all clustered around a certain, they clustered together. And if we look out, going out from, we did numbers from 2015 to 2030. And basically what we saw was that the number of these non-responders was increasing. And that was based on aging alone. Again, one of the key risk factors for PAD and CLI. But then if you think about the increasing prevalence of diabetes, if diabetes and chronic kidney disease continue to increase as they have done over the last 20 years, we would have even a faster increase in this group, which is really tragic. And both of our doctors here have mentioned the changes in their patient population and what they've seen over time. And basically, we're just going to see more of that in the future. And from my perspective, it's very frustrating, because if we started screening just even the high-risk groups, let alone everybody over age 65, if we started screening those people, we would find disease at earlier stages, and it could be treated less invasively. We could reduce amputations and improve life and limb. And just not to belabor this, but we screen for cancer. We screen for breast cancer. We screen for colon cancer. We don't wait till the patients have symptoms. We don't wait till they're stage 4 to find it. The whole point is to find it at stage 0 or 1. So it can be treated less invasively, and it costs less.